Assalamu alaikum warahmatullahi wabarakatuh. Auzubillahi minash shaitanir rajeem. Bismillahirrahmanirrahim. Now we come to the last part of our discussion on obstructive jaundice, the case scenario. Till now, we have discussed this scenario that probably in a 75 years old male with 3 months history of progressive jaundice with anorexia and appreciable weight loss, having a palpable mass that is a globular distended gallbladder, our most probable diagnosis based on the basis of history, clinical examination, investigations has turned out to be CA head of pancreas. So now what would be our plan to manage this case? Once the diagnosis has been made and the disease has been staged, management plan is made. According to case scenario, most probable diagnosis in this case is obstructive jaundice due to carcinoma head of pancreas. Very important in these cases is the preoperative preparation. This is very important. Without preoperative preparation, you should not go for a major surgery in these cases. That would be fatal. So proper preparation of these cases is very important. And what are the steps in that? IV fluids and electrolyte replacement to prevent dehydration. Number 2, IV glucose, usually 10%, because there is abnormal glycogen metabolism in these cases. But please, before administering this glucose, try to find out that your patient should not be diabetic. In diabetic patients, you should not go for this. Then vitamin K administration to prevent bleeding. Diathesis, because as you know, there is no bile which is going into the no bile is going into the gut because of obstruction, and when no bile is going into the gut, it is not absorbing any fat soluble vitamins, and one of the most important fat soluble vitamins is vitamin K. So there is deficiency of vitamin K, and all the vitamin K dependent clotting factors will not be formed by the liver in this case. So that would result in an abnormally prolonged prothrombin time. So in this case, vitamin K would be administered systemically, either intramuscular or IV. Sometimes fresh frozen plasma may be required when there is severe coagulopathy. Next step is IV antibiotics, and normally second generation cephalosporins are enough to prevent infection in stagnant bile and to prevent endotoxemia. Another important medical management in these cases is oral lactulose administration. This lactulose actually absorbs the intestinal toxins, and again it helps to prevent endotoxemia leading to hepatorenal syndrome. Once we have prepared the case, once we have arranged the blood, once we have come to know that our patient is operable, then we plan the surgery. Remember one thing, in operable cases of CA head of pancreas, there are two options. One is the standard Whipple and other is the pylorus preserving pancreaticoduodenectomy. In pylorus preserving pancreaticoduodenectomy, as the name signifies, the pylorus of the stomach is preserved, and the pancreas head along with part of the body of the pancreas is resected. And the anastomose along with the part of the duodenum and initial part of the jejunum. Gallbladder is removed. So what would be left behind would be part of CBD, tail and some part of body of the pancreas, and the whole of the stomach plus pylorus. Then these would be anastomosed with the jejunum. The first anastomosis will be with the remaining pancreas and the jejunum. The next anastomosis will be in between the end of the CBD and the side of the jejunum. This is called end to side choledochojejunostomy. And then the anastomosis between the pylorus and the jejunum. So these are the three reconstructed anastomosis which are shown in this picture. So this is pylorus preserving pancreaticoduodenectomy. This is standard Whipple's, in which the pylorus has been resected and rest of the anastomosis are same. There is pancreaticojejunostomy, there is hepaticojejunostomy or choledochojejunostomy, and there is gastrojejunostomy. These two operations are described in case if the tumor was resectable. If the tumor was not resectable, then we have to go for certain other options, and that is either we go for cholecystojejunostomy, that is anastomosis between the distended gallbladder and the jejunum, or choledochojejunostomy for the drainage of bile. Gastrojejunostomy to prevent gastric outlet obstruction by involvement or compression of the pancreatic tumor on the duodenum, and jejunojejunostomy to prevent jejunal reflux to the stomach through gastrojejunostomy. This is shown in the next hand drawn diagram in the next slide. So you can see that an inoperable pancreatic tumor is there which is causing compression to the duodenum, and this compression might be causing gastric outlet obstruction and repeated vomiting. This tumor is also causing obstruction to the CBD. So to prevent these, to overcome these things, we have gone for gastrojejunostomy, choledochojejunostomy, and jejunojejunostomy. This is called as triple bypass, and this is a palliative procedure. At the end of this discussion, the things we should know, and you should find these answers through different learning resources. Search the books, go to the internet. And what are these questions? What is the pathophysiology of hepatorenal syndrome? What complications may arise if we do not prepare this case properly before surgery? That is, we do not preoperatively prepare a case of obstructive jaundice before surgery. Number 3, what are the complications of pancreaticoduodenectomy? And this brings us to the end of our discussion on obstructive jaundice. Now you should go through these slides again, go through the literature, search for these questions, and I hope that you would be able to understand the topic. If there are any queries, this is my WhatsApp number, and this is my email address. You can ask me through WhatsApp or send me an email if you have got any queries. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.